Well, welcome, Dr. Bakris. Dr. Bakris is our CMHC Co-Chair, Professor of Medicine, and at University of Chicago Medicine. Welcome, Dr. Bakris.
Good to be here. Thank you.
So we'd like to go over your talk of inflammation and evolving concepts and treatments in hypertension. How does inflammation contribute to the burden of hypertension, and what have we learned?
Well, this is a very important question, and I think the audience needs to be aware that inflammation comes from a whole host of different things. And the most common source of inflammation is not pain. The most common source of inflammation is obesity. And obesity begets diabetes, and you have a forest fire on your hands. That is inflammation. And if you don't believe me, look at all the data of the people that have had bypass surgeries or anything, have lost 70, 80 pounds over the span of 6 months. All of their numbers, I don't care what you're looking at, have reverted to virtually normal. Blood medicines melt away. So it is a major problem. What happens is these are immune responses. Fat cells release aldosterone. Aldosterone in higher amounts than normal is actually bad and stimulates a whole host of reactions with immune cells, which is too complicated to get into here. But those responses contribute to cellular inflammation, and the body, of course, reacts to cellular inflammation, and sometimes it can't beat it. And so if it can't beat it, it ends up chasing itself around, it's chasing your tail. And it's a problem because what ultimately happens is you get fibrosis. And once you get fibrosis, the party's over. It's like I tell the patients, if you put a piece of metal out in the rain and you forgot about it, but you really wanted to use it down the road, and now it's half rusted, you're not going back. And so that's the way you have to think about it.
So what is the art of current management of hypertension, and what are some important pearls you can share on making sure that patients achieve their BP goals?
Well, I'm going to answer that by a comment that was made to me by the director of the kidney heart unit at the FDA. You have 125 blood pressure lowering medicines in 8 different classes, and you can't manage blood pressure. So that means one of two things. Either A, you don't know what you're doing, or B, the patient's not taking any medicine. And the truth is, it's probably a little of both. Now, that's almost a direct quote. So the problem is that physicians are combining medicines because they're all blood pressure lowering medicines. It turns out that combining blood pressure lowering medicines, if they don't have complementary mechanisms, they're not going to work. Beautiful example seen all the time, beta blockers combined with angiotensin receptor blockers or ACE inhibitors. You get nothing in terms of additive blood pressure reduction. Good for heart failure, but the mechanism has nothing to do with blood pressure. So you need to understand what you're doing. It's been very clearly defined. We clearly defined this back in JNC 7, 2003. Diuretics, ACE or ARB, CCB. That's the triad. And any combination within that triad is going to work. Combinations outside that triad, like our friend clonidine or hydralazine, this is not 1975 anymore. We need to use medications that have been proven in outcome studies. And the reality is, there is resistant hypertension. It is real. Unfortunately, it's nowhere near as real as people think. And the reason for that is because patients don't take their medicine. And it's not a yes or no. I asked the patient once, are you taking your medicine? Yes. Are you taking it every day? Well, no. I take it maybe 3 times a week. And well, why are you doing it 3 times a week? Well, I don't want to get too much medicine in me. I see. Okay. Are you taking all the medicines when you take them every day? Well, no. I stagger them out. You need, I know that's stupid, but you need to ask the patients that level of questions if you want to get at, are they taking the medicines or not? That's the most common cause of poor blood pressure control. And FYI, the latest data suggests that we're doing worse. We were doing better for a while. Now we're doing worse. So the reality, you can't blame everything on obesity. So this is really a problem with adherence to medication and, unfortunately, poor communication with the physician. It's not the physician's fault. It's that our friendly administrators have given them X amount of time, and if they don't see the patients in this time span, and guess what? You don't have the kind of time you need. I have the luxury of having more time with the patient, so I explain all this to them, and they tell me no one's ever told me this, and I don't have a problem with adherence. I do, but it's a minority problem. It's not a majority problem. So it's a big deal. And the last thing I want to say is you have to take blood pressure properly. The slam bam, thank you ma'am, when they pop in, they're late for the appointment, they're rushing in, the nurses sat him down, they haven't even taken a breath, and boom, you measure the blood pressure, they're hypertensive. No, wrong. So you really do need to do this appropriately, or you're going to have a lot of white coat hypertension that you're treating, and guess what? Doctor, I can't take this, I have side effects. Well, of course you do. Your blood pressure is 120 at home. So these sound stupid, but they're unfortunately all true. And these are not rare cases. These are happening all the time. So it's important to look at complementary mechanisms of agents to treat blood pressure. The next thing I'm going to tell you is, in patients that have some level of kidney disease, I'm not talking about dialysis. I'm talking about GFRs of 40, 50, and somebody puts them on an ACE or an ARB, which is mandated by guidelines, and the creatinine goes up a little bit. Oh my God, we're stopping everything because we've caused kidney injury. You know, you haven't done any such thing. And so it's important to not stop medication for a 10 to 20% rise in creatinine, as long as it's stable and you don't have hyperkalemia. And even if you do, you should use a potassium binder, because those drugs, and I don't have time to give you a lecture now, but the point is those drugs actually do save kidneys if you use them in the right dose. Low doses do nothing. The joke I used to say is lick doses of enalapril. You take 5 milligrams, lick it, and put it back in the bottle. No, that does not help you. Not at all. Even if you take it, it's not going to help you. You need the doses used in the trials. So doing that, if they have kidney disease, an SGLT2, and if they have albuminuria that's still present after an SGLT2 and blood pressure medication, then you add finerenone, the new nonsteroidal MRA. You'll get some blood pressure reduction again, but you'll get big-time anti-inflammatory effects. And that over time, not immediately, but over months, will give you some drama in terms of reduction of albuminuria.
Thank you, Dr. Bakris.